So good afternoon, everyone. I hope everyone had a really nice lunch break. We had an amazing morning. Great presentations from our trainees, wonderful faculty presentations in the special symposium, and a great panel discussion. So I'd ask everyone to kindly take your seats, and we will get things underway in just a minute or two. And I wonder if I could kindly just have my introductory slides on there, please. Yeah, thank you. Are they on the left? That's his notes on the right, and that's on the left. Okay, great. Okay, no worries. No worries. Thank you. Okay, very good. So we're very honored to welcome Professor Nataraja to Toronto to deliver our Gordon Murray lecture on driving change, the impact of low-cost simulation-based educational innovations in resource-limited settings. A very, very apt title given, the theme that we have been discussing. So Professor Nataraja is delivering the Gordon Murray lecture, and this is a photograph of Gordon Murray. And this lectureship was endowed in 1981 by Gordon Murray's family, and for many years we had the pleasure of having Rosalind, his daughter, join us, and unfortunately she's now passed, but she was a very vibrant advocate for her father's memory. So Gordon Murray had a very distinguished career. He was a veteran of World War I, and in fact was very severely injured. And it's remarkable that he actually survived World War I. It's quite a story. And then he had quite an extensive training. At that time, residency training was not as well organized and as structured as it was now. He spent time in England, and then eventually became a surgeon at Toronto General Hospital, University of Toronto. And according to my mentor, Charles Tatter, who actually worked on his service, I think, as a medical student, he was an extraordinarily gifted surgeon. One of the areas that he is known for is pioneering the use of heparin in surgical practice. So it's in his name that this lectureship is named. So here we are in 2026, and this is our Gordon Murray lecture. You've already met Professor Nataraja, so he made some comments in our panel discussion. And so when I was actually linking with George Azi, who I want to give a lot of credit for, helping to come up with you know, the name of this speaker as well as Stan Hamstra was very clear. It was a very clear recommendation, and I can certainly see why. So these are a few of Professor Nataraja's titles. So he's a consultant pediatric and neonatal surgeon at Monash University in Melbourne, which is a very distinguished university. A lot of parallels, in fact, between Monash University, University of Toronto, I think, and between Melbourne and Toronto. So in addition to his clinical practice, he is professor of simulation-based education as well, and he's done a tremendous amount of work and has had a huge impact with over 650 simulation-based activities, and you know, this has had a huge impact, a tremendous international collaborations with a number of organizations, including the WHO, where he's also served as a consultant in surgical education. And Professor Nataraja actually has dual citizenship between the UK and Australia, and we were having a very good discussion over dinner last night, kind of related to this. So he did really his foundational medical training and surgical training in the UK, and then for personal and partner reasons came eventually to Australia. Very good reason, indeed, and he's a recipient of a number of awards. I just highlighted the Monash University Vice Chancellor's Award for Excellence, and he's also a Senior Fellow of the Higher Education Anatomy. And with that introduction, Professor Nataraja, I wonder if we could call upon you to deliver your 2026 Gordon Murray Lecture. Thank you.
Thank you very much, and thank you for the introduction, and thank you for the invitation to be here. It's a great privilege and honour to be here with you all, and it's great to come all the way across the world and meet such a huge amount of like-minded people. So it's a great pleasure to be here today. So I'm just probably following in Laura's footsteps here, going on a bit of a pivot away from robotic surgery and going to the other side of low-cost simulations, but certainly our work in low-resource settings as well. I'd like to acknowledge my team back home, so Monash Children's Simulation Team. So when I first joined Monash 11 years ago, I was director of myself, and we were still building the centre. I was a bit of a hard boss, but I got the work done in the end. But we've now expanded, so we've got Preeti and Demir as now onboarded this year as a medical and surgical lead, so we are expanding. And I want to acknowledge them because none of the work that I'm presenting here is me alone. It's actually the team behind me and our wider team of students and postgrads who actually contribute as well. And one of the other things I like to highlight, which is probably unique to us, is it took us 6 years to get it signed across, but we've actually got an official collaboration agreement between Monash Health, which is our healthcare provision, which is a huge healthcare provider in Melbourne, and Monash Uni, so signed off by the Dean and the CEO for a collaboration agreement to actually put MCS in between both organisations and helping both at the same time. And in addition to the introduction, I feel very blessed in the fact that my practice is paediatric, although it seems to be expanding as well. But I have a clinical practice. I'm a general paediatric surgeon. I'm very active in the department in terms of actually the running of it as well. But I also have simulation. So, and simulation has always been a big part of my career so far, and I'll acknowledge some of my previous mentors in a second. But it keeps things interesting. And then global health as well, which is very simulation-based as well, and that's where we're really going. But one of the things I was really interested in here is that I kind of forged that academic career by myself. I found mentors who supported me and put it through, and I'm very keen to actually hear about the academic pathways here at the University of Toronto, where things are more formalised, and I think that's an excellent model which we need to incorporate as well. I'm a product of my mentors, and I think so you may recognize some of these, but Ed Kiley was a consultant at Great Ormond Street, and although he probably didn't label it as much, he showed a lot and taught me a lot about emotional vulnerability in our clinical practice, about owning complications, about really bringing them down, and actually really being a very reflective practice clinician. Munta Haddad on the bottom left was my mentor at Chelsea and Westminster, and he taught me paediatric surgery, but also that there's much more about being a paediatric surgeon than the technical side of things and dealing with the families, and that actually we teach and we deal and actually manage the families as well as our patients. Liz McLeod at the bottom right, she's an amazing educator and an amazing global health advocate, and she put me onto the path for global health. And then Joe Curry is an amazing mentor who put me not only on the path for paediatric surgery, but also for simulations. So in 2002, he started my journey with the GLUB model, which I'll show you in this presentation. But I also want to acknowledge the University of Toronto. So yesterday I had lunch with one of my colleagues from the Wilson Centre, who I've been working with for many years virtually, teaching into our Masters of Clinical Sim, and it was wonderful to finally meet her face to face and have lunch with her. And I think I acknowledge, and there's obviously people in the audience here who are great pillars of educational theory and also practice at the University of Toronto. So I want to acknowledge them. And also someone else who's in the audience here who will probably have a red dot following me around now that I've mentioned him here. But George is an amazing resource. He is one of the pioneers of and innovators in surgical simulation and also global health. And I think that nothing that I have done and nothing that I am doing would be possible if it hadn't been from pioneers like him, and I'd like to acknowledge that as well. I'm going to be taking you on a bit of a journey. I'm going to be talking a bit about simulation-based education, because I know that following on from the speakers at the last session, and talking a bit about low-cost simulation as well, which is one of our key areas. I'm going to take you on a journey through the Myanmar experience, which was our first simulation-based program within a low-resource setting. Talk about two of our programs, the Monash Online Surgical Training Program and Pivots, which is the Pacific Islands Virtual Online Training in Surgery. And there are virtual programs. And also talk a bit about pediatric simulation-based education, because we have a big arm of our practices that, and really that simulation can change differences in cognitive skills as well. And I'll just acknowledge that as well. People ask me what is simulation, and I think this sums it up for me. This is Maurizio, one of my academic colleagues, and we're down in Bairnsdale, which is about a rural centre, about 4.5–5 hours from Melbourne. We're running a workshop, a trauma workshop for medical students, and this is Maurizio, who's teaching an intraosseous needle insertion, so putting in for resuscitation of a child. But if you look at the faces of those medical students, this sums up to me what simulation is. There's a range of emotions. I think one of them hasn't quite figured out what's happening yet. But there is a range of all those emotions, from shock to, just what is happening here. And I'd rather the students have those adverse and really kind of extreme reactions in a safe environment, but not when they're standing over a child and they need to put an intraosseous in seconds to actually save the child's life. So it's a safe place where they can really get those emotions and really come to grips with things beforehand. But what are we using? We're using these simulators, which is not our invention. It's something that has been well described over the years. And it's a crunchy bar. I'm not sure you have crunchy bars here, but wrapped in elastoplast. It's got very high fidelity. You have the resistance as you're really squeezing and twisting it in. You suddenly get a give and you get a nice crunch as you go into the bone marrow or the honeycombs. So it doesn't have to be high cost, but is very, very effective. But I wouldn't recommend eating the chocolate bars afterwards. It's after they've been gone. There's many definitions for simulation, this is my one, and it's the acquisition and maintenance of essential technical and cognitive skills in a safe, controlled learning environment prior to patient contact, hence ensuring patient safety and clinician preparedness. And one of the differences in my definition is maintenance. So we talked a lot about the acquiring skills in a safe environment, and that's certainly a large part of what we do with simulation-based education, but maintenance is as well. And this isn't a foreign concept. One of my close friends is a pilot. And even though they fly the biggest jets in the world routinely, they have to spend a huge amount of time on a simulator every single year to maintain their practice. I do that with my practice with a thoracoscopic neonatal diaphragmatic hernia repairs. We've got a simulator that helps the sliding knots. Only time I use that knot is for that condition, and not all babies with that condition are suitable for minimally invasive repair. So I do one maybe 2 or 3 times a year. So before I do that procedure, I throw 20 to 30 knots on my simulator. Doesn't take me long. When I go to the patient, then the first knot I throw may not be the best knot in the world. I'm sure many people in this room maybe throw a better laparoscopic knot than that, but it's the best that I can do, and I've got over that learning curve and I've prepared for it. I've had that preparation, which is something we're now evolving and catching up with SIM, is the maintenance of skills as well. In terms of my simulation journey, so this is a double glove model I created with Joe Curry at Great Ormond Street. It's a water-filled glove with then ovals on the outside and an IV giving set in between. When we did the first study with, we had 13 to 14 participants, we had to beg, borrow and steal equipment, go into theatre after hours. I had to take the equipment down to sterilisation services to make sure it was ready for the list the next morning. And it took a lot of chocolate to bribe the nurse in charge to let me do this. But now we have simulators. We have low-cost simulators, and as you'll see, we have simulators which are actually home-based as well. So in terms of the glove model, we've got a validated system, and although we've moved on, and Demir, who's now joined us for faculty, did a study looking at our scoring system at over 120 surgical trainees. And we actually demonstrated there was a difference in the skill level with this model. So this is now something that we use objectively in our teaching programs to actually assess the acquisition of skills, but the model itself costs about 4 cents to make. And just because it's low cost doesn't mean that it can't form new ideas and new educational theories. And this is the glove model where we ran a workshop. We then did a randomized controlled trial with medical students and novices and put them into individual or dyadic practice. We then assessed them, and then we did a follow-up assessment as well. Now, my aim was proved in this, in the fact that the team that worked as a dyad, so in a group or a pair, actually had the same skill acquisition, half the time on the simulator, but actually had the same skill level. And the interesting thing, even though we're using it as a low-cost model, is that there was long-term retention of skills in the group that actually worked as a pair. And this is the peer-to-peer support, and also very much the mirror neuron theory that comes through with it, in the fact that the group that worked in a pair maintained their skills at a retention test, whereas the group that actually worked by themselves dropped down to their original baseline level. So there was longer term laying down of skills, of laparoscopic skills. And in terms of forming a low-cost simulation model, there's a process. It's the same for a high-cost one as well. But we need to think about what are we doing it for, what procedures. We need to think about the frequency of those procedures. So sometimes it's the high-frequency ones we want to teach. Sometimes it's the low-frequency. It's the very rare events that come on, which are actually probably better equipped to actually dealing with simulation because people aren't exposed to them as much as they have been. We have to chunk it down, and we've spoken yesterday about chunking things down into the actual processes. And that's one of the hallmarks of good surgical practice, to break an operation down into individual steps. And when we're developing it, we need to think about those steps, which steps we can actually simulate, which ones we can't. Simulation is not replacing surgical practice, it's enhancing it. And it may be that we can only do 6 or 7 out of 10 of the steps, but that decreases the cognitive load of the students when they actually do get to it. And we need to think about the design, we need to think about the money of how much it costs, we need to think about the process of making it. If you can only make the model with a very high-tech engineer, then it's probably not worth doing. and think about the actual time it takes to make it, and then think about the steps. How do we validate it? And start to think about how do we score it? Because it's not just a simulator, it's actually the scoring systems that come along. And then how do we then make that as actual objective marker of skill progression? We need to get feedback. We need to get feedback from experts. We need to trial it. We need to run trials to actually see it. And then we need to validate it. And then we need to really think about learner experience as well. And then we need to think about sharing it. And certainly a lot of our models now, we're 3D printing them and putting them up on open resource sites for people to download. We were talking about this, and there's obviously the University of Toronto was instrumental in this, and I think this is why we do global surgery, and there's obviously a shift. The only thing that it does make you wonder, we're actually closer to 2030 than we are 2014 now, and there's still a long way to go. And I think although it was a call to arms, we still need to really push forward for that. Where 2030 is not that far away anymore. And I don't probably need to say to a lot of people who work in global health, but there's equality, but also equity. But for me, it's the next level. It's social justice. It's actually removing that barrier so they don't need to have something to step on. It's actually getting them tickets or making the tickets more accessible to everyone to actually be part of the normal crowd. And then actually the next step is they could be the players. Why are they not the players? Why are they stuck behind a fence? So it's actually going to the next level for global health. And to this end, with partnership with our College of Surgeons and also Fiji National University, we've got portable training labs all around the Pacific and as far as Bhutan, Myanmar, and then going forward as well. So we've got portable training labs all through the region in low resource settings, and I'll go through a bit of the breakdown of that. Starting with Myanmar. Myanmar is our first experience of that, and I'd really like to acknowledge Yinma U, who's an amazing educator and surgeon and was our counterpart and surgeon there, and she's on the left there. And this is our faculty. So we were in country for 7 years before the Civil War, and we actually trained them up. When we started there, this was part of a wider process that we helped them with devising a curriculum. But there was only 5 pediatric surgeons for the whole country when we joined. 2 of them were post-retirement age. When we left and couldn't come back anymore because of the Civil War, there were 22. So huge, not just us, there were big interventions going on as well. But we actually then had that very satisfying thing of they became our faculty. And we did simulation-based education. We set up training labs with no electricity. We did laparoscopic training to really accelerate their practice, but also neonatal resuscitation, trauma, using tracheostomies, and all the other things that will look very familiar to everyone here. And that was part of a much wider program, as I said, and towards the end of it, we handed over to them and they took over. And one of the most satisfying things for me as an educator was the fact that I was watching what was happening and having no idea what was being said. So I could tell that they were doing simulation, that they were doing the right thing, and I was looking at them going, well, actually, they need to correct this, and then they would say something in Burmese, they would then correct it, and they would see it. So I would see the in-action correction for that, but I wouldn't understand what the Burmese language they're actually saying. But one example I want to bring from this is actually, and we had about 161 in total through the program, and that for the basis of pediatric surgical curriculum there for them. But the one thing I want to highlight is the interception, which we did fairly early on. So some of you may be very familiar with interception. It's the commonest cause of small bowel obstruction in babies, where the bowel telescopes in on itself. You can do an operation to fix it and actually milk it back generally, and we do still have to do that in high-income countries if there's necrotic bowel. But the majority in high-income countries have a non-operative approach now, so over 90% do. And what we saw is from the preliminary discussions is that the majority of babies in Myanmar were actually having operations for this. So we used local regional contacts. We had an interception air enema machine made up by our Vietnamese colleagues for a couple of $100. We donated that, and we set up a program for them. And this is the Indy. So this is Indy, which is a doll which I got from Kmart. I got various plumbing stuff from Bunnings. I traumatized my then 2-year-old daughter by, she walked into the kitchen and saw me drilling a hole for a bottom. And she said, Dad, baby, no, no, baby. But I think she's forgiven me now. She's now 11. But we x-rayed it, we validated it in our setting. But again, it cost us $18 to make this. And then we went in country. We did it in the radiology suite. We trained the radiologists. We trained the surgeons who did a lot of the surgery. And thanks to Yinma, we then did prospective data collection throughout. And that's one of the important things. And we compared that to a retrospective data set. And what we found is actually with 80 patients per year, we actually decreased the operative rate. And we went from 80% to 50%, and then it stabilized. The intestinal resection rates reached international standards. So although it seems to have gone up and that's a bad thing, it's actually a good thing because it means that if you do need to resect intestines, then it means that the non-operative technique wouldn't work. So that's actually international standards for that. Very good recurrence rate, very good success rate. But I was disappointed. I was disappointed it didn't continue to drop, and as we saw, and it had plateaued. But this is where the research methodology comes into it, and we did qualitative interviews with them, thematic analysis, and we found out that this is the gold standard for Myanmar. There were only 2 major centres for the whole of the country, so the presentation pattern of children, the availability of the X-ray machines out of hours, this was actually the best we could achieve, so we moved on to other projects as well. But the power of this is actually more so than just the child not having an operation, which is a great outcome for us. But you can see here, this is the length of stay. So on the left-hand side, you've got the operative. On the right, you've got the air enema. Still higher than what we would do in my setting, but it's come down significantly. But bear in mind the healthcare, so not only less inpatient days, less drips, less fluid, less antibiotics, less small bowel obstruction, less complications, has a huge cost saving to a service. So this really kind of proved that we had sort of a level 4 Paediatrics levels, and I think that we do debate about the validity of Paediatrics levels at length, but it is one way to evaluate it. And I'm proud of Yinma, despite the civil war, this was last year, she's still a champion of simulation-based education in Myanmar, and is still going forward promoting that there. So then to talk about MOST. So MOST is, and we talked a bit about this earlier, this is what we used to do. So we built a simulation centre that was all singing and all dancing. We've got trainees from all around the country come down, run our courses. We had OSCE type stations, people rotate through. We did cognitive skills, we did technical skills, we did laparoscopic simulation. And they used to come to us. But then this little bug happens, and I think that Michael has said about how it promoted innovation, and for us it did. So COVID happened, and people couldn't come and visit us. So we devised a course, a virtual course. We turned it completely on its head. If the trainees can't come and see us, let's send them simulators. So people signed up for it, and we sent them a laparoscopic simulator, and they then worked at home. And then we realized that throughout this course with all of the different components, which I will show in the pivots, we were teaching people up in Darwin and Perth from our base in Melbourne. So, and then with my global health interest was actually, we're teaching people from Darwin when I'm down in Melbourne, which is about a 5-hour flight away. Why can I not teach the Pacific Islands as well? And when we evaluated it, and this is Sam looked at it for us, there was a strong female presence there. But we did all the laparoscopic simulation we'll go through, which is actually relatively straightforward and low cost. But it's validated, and it doesn't look like an operation, but it really teaches you all the core skills you need for laparoscopy. So things that have been championed in the past, such as depth perception, hand-eye coordination, the fulcrum effect, altered depth perception, and all the other factors that we use in minimally invasive surgery. But you can see here we did get them all suturing at the end. So all of our participants at the end of the 6-week course start to do sliding knots, start to do sutures under tension, and actually get very good at it. With the thematic analysis, very much the educational theories of what we did came through. So they really benefited from being active. They were an active learner. They really appreciated the real-time constructive feedback from the webinars where we looked at their performance on Zoom. The repetitions, the deliberate practice really came through as one of the factors, and home simulation base they really resonated with. Individual learning needs, it was a tailored program, and it had a safe learning environment, and they actually really appreciated the self-directed learning. And there were elements to it that I'll highlight in the Pivots program because we adapted this program for our international arm. But I'll just highlight this comment here, which is that practicing with the instruments in a safe and non-judgmental zone, i.e. at home, so I can finally start to do more in theatre and be taken more seriously by my seniors. Yep, so it's that safe environment for them to do. So Pivots then formed from this, so very similar in many ways. We've got the LMS, which is a 6-week course, and it actually has all the fundamentals of surgical practice. So for the core, it's prepping and draping, and very core skills, and then we move on to the higher advanced cognitive skills. One of the key things is we have an online curriculum for surgical progression, but metrics tracking, which I'll go into a bit more depth, but that's actually with the instrument tracking to give system-generated feedback to them. We had the webinars, the same as we did for our MOST course, and evaluation and evolution is built into it. Everything we do is linked to our learning objectives, and we actually built it in. Too much in my early career, and I'm guilty of this as well, I used to design an educational course and then say at the end, oh, maybe we should evaluate it and tack something along at the end of it, oh, quick, let's get a survey up, that'd be a good idea. But it should actually be built into it. It should be actually, what are my learning objectives? Am I achieving them? And if I'm not, why? And so actually evaluation brings right back into the beginning. And faculty development is very key for us. And so far we're in different countries. So we've in Fiji, Samoa, Vanuatu, Solomon Islands, Papua New Guinea, and also Tonga are our main places that we work through. And we've had 337 doctors from O&G, general surgery and nurses enrolled with an 87% completion rate so far. And this is haiku. We've also got people to go through my program with a graduate certificate of clinical sim as faculty development, so training them in educational Monash University qualifications to take over the program as we move forward. It's a 6-week program, so webinars, online platforms, discussion forums, but we test their skills. So all of the participants go through the double glove model. We then go through the different 6 weeks. We then test them again and then do a retention test as well. In terms of the learning management system, you can see here it's just the same as any Moodle I think anyone will be familiar with as we go through. But one of the things I'll highlight for the advanced is that it's the real cognitive skills that we're looking at here. So clinical governance, how do we stratify complications? How do we deal with de-escalation of situations? All key skills and cognitive skills that make a bigger impact for patient outcomes than the technical skills alone. And we have simulators that collapse down into little briefcases. We have our own simulators we now get made. And these are all less than $1,000. So the fact that you can really get them out and actually where they're needed. And we had a bit about access to it as well. So we actually we got laptop stands, which we then put simulators on top of and actually then leave them in the theatre. And because they're low cost, they can actually be there and actually they do take care of them, but it doesn't matter if they get broken. And the simulators you can see here, this is on a bed, so just in a room in Fiji, forming one of our workshops. And we've got 50 simulators through our partner companies in the Pacific. So 50 of these are throughout the different countries. And they're actually, the core and advanced is now a home-based program. The trainees get it to stay at home. And I saw with the presentations at the previous session that it's a great initiative for home-based, and that's obviously what championing here as well. And we use a lot of the low-cost simulation. A lot of it doesn't look like proper operations, but it does give you all the skills, as we said, and we have objective markers of their skill. And the die stacking is a great, I don't know, probably many of you have done it, but it's a very difficult task and advanced skills. But it doesn't really feel like a real operation skill. But when we were last in country in February, one of the advanced trainees was very excited and said, I finally figured out what it's useful for. And he said he got called in by one of the juniors who was starting out in their journey with a lap chole and had a big gallstone that had escaped, and they'd already spent about 2 hours trying to figure out how to get it into the bag. And then he said, I just used the same skills as the dice. I picked it up with both instruments and dropped it in about 30 seconds. So it does correlate. But what I said is about the system-generated feedback is that we track the movements of the instruments. So you can see here, this is the kind of feedback they get for every single procedure that they do. They get their distance travel, they get the handedness, they get the off-screen, the speed, acceleration, and the motion smoothness as well. And you can see this is the lace threading, which is a very fundamental laparoscopic task. And you can see it should be about 50-50. This trainee's doing well. They submit assessments and they get a global score, they get written feedback, we watch their videos and we go from there. And just like most, we get them to do webinars and we can really take them through suturing and the advanced skills. We obviously start at a lower level and build up. But it creates a community of practice throughout all the Pacific Islands. So there's a really big community of practice now where they support each other. And the journey with FNU is actually with a memorandum of understanding. And one of the things as an educator that really resonates with me is it's now mandatory training. So the core course is mandatory training for the first years, and for the second years it's mandatory training for the advanced course. So this isn't just you're coming, giving us equipment, giving us free access to educational resources. They're assigning value to it, they're making it mandatory training. And actually the feedback we get from Abe, who's our lead, is that actually it's great because he doesn't have to teach them all and it frees up his bandwidth to do other things with them because he knows that the various domains that we target are actually taught, and actually he doesn't have to worry about them. And we do loads of good workshops, and people say to me, if you've got a 6-week educational virtual program, why are you actually doing a workshop? But it really gets the learners engaged, gets them together as a group and really helps in the discussions. And then we repeat them on a rotation throughout all of our other countries. In terms of the tracking on our systems, so this is just a snapshot of some of them and includes, the overview includes some of our recent data, but we've had more than 6,000 laparoscopic tasks logged on our system. Not all the tasks are actually going to be logged on there because you do have to have internet capabilities. And that's over 500 hours of simulation practice within this program and 90 hours of direct observation and feedback. And I'm very, very keen, we're working with an engineer to use AI to automate that because myself and my faculty, although we get very good at it, would like to minimize the amount of hours that we watch them perform. Feedback's very vital, so we look at domains, and one of the things I love putting this up is that I was always told that there's no point asking feedback from this setting, they'll just give you 10s all the way along. You can see that they don't, and some people really doesn't resonate with them. And it's the feedback from those participants that I'm really interested in. Why didn't it work for them? What can we improve for it? There's a lot of fault and a lot of debate about self-rated Likert scales for confidence, but we link them to our learning objectives and pre and post course. The majority go up, but not all of them. So things like conducting a ward round for the advanced trainees doesn't go up, although it does, and not significantly, but it does go up in terms of the overall score. And that's because they do ward rounds all the time. It's part of their core practice. And as we said, objective skill improvement, this is a glove model for, there was a suggestion we should do a 6-month program, not a 6-week program. But you can see the skill levels go up significantly for the first 6 weeks and then plateau. So actually we were achieving what we needed to achieve within the 6-week program. But it's expanded, and one of the things that our colleagues said is that we don't work in silos. Our nurses are a rate-limiting step. They don't understand laparoscopy. They don't really want us to start because of the barriers there. So we designed, with my nursing team, an online course as well. So 6 weeks, we take them through, and we've had 50 enrolled nurses, perioperative nurses, going through that program as well to really enable the initiation of laparoscopy within these settings. And again, they've had very good feedback for that with the learning objectives, achieving significance, and also a range of responses indicating honest feedback. And just some of the comments we've had from it, because it's the last couple of years we've been doing it. And this is just someone this is a Fijian participant who's really saying, actually the virtual methodology, the virtual techniques it's different. It's not what they're used to. There's challenges with it, but it does resonate with them. And this is a really one which I would put a lot of value on, which is actually one of our Fiji National University nursing colleagues who wrote to us because they were an observer on our course, and actually said, and she says here, as someone who both supervises nursing students in OT and the assessment unit and teaches perioperative nursing to undergrad students, I've come to see how valuable this grounding is for my own practice, my mentorship, my leadership, and the quality of education I can offer it. And she wants to become a participant on the course to enhance her own practice. So for me, faculty wanting to engage is key. And so the Pivots program has expanded from the core to the advanced, the nursing. We do an educators course as well, so clinical educators course. We also got scholarships like Haiku. We've had 3 scholars through so far. We're expanding it next year. And we're now designing a research course to enable them to capture the clinical data as laparoscopy is then introduced further. We have our core countries, and we're now establishing in all countries portable training labs and working with Pan-Pacific organizations like PIORNA, which is a Pacific Perioperative Nurses Association, to get it out to all of the people who need this educational resource. And just a bit of a nod to our paediatric interventions. We've worked in Papua New Guinea with Pivots, but also with Paediatric Medical. So the same thing, we worked with experts, created an LMS. We launched it in COVID, so when I couldn't go more than 5 kilometers from my house, we actually ran webinars. We trained them, they delivered it, and they did it in country. But then we had the pleasure of going in later on, a few years later, to actually then consolidate those skills. And this just proves you need higher level engagement. And this is the Australian High Commission who's actually putting on social media about the program. And it's very important to have that high institutional buy-in for the programs to make them work as well. And we've had about 200 healthcare workers through. And this is one of the things that the comments here, this is from the sister in charge of the A&E department there, or the ED department, the children's outpatient department. And what she's saying, and I'll leave you to read that, is actually, for me, this is incredible feedback for simulation. She's saying that they had a baby that came in the week after we did simulation training with exactly the same presentation. And actually, this time they managed to do a successful resuscitation. They had a successful outcome. And actually, they really assigned that to the fact that they'd run through it in simulation-based education the week before. And just a few nods to what we do. We run low-cost simulation for the point of return at Monash. This is not internationally, but at Monash. It's mandatory training for our grad nurses to recognize children who deteriorate. We've had more than 800 nurses through with increases in their competence or self-rated competence within its limitations of that technique. And also for low-cost simulation, and they're one of the colleagues I met up with is a world leader in simulated participants, and we've trained more than 350 staff in the management of clinical aggression. So this is kids with neurodiversity with code greys when they actually get to a certain level, and now we're teaching multidisciplinary teams in simulation to de-escalate so it doesn't get to a code grey, and it's working. And we're getting pharmacists, we're getting allied health, we're getting security through the program as well. So just before I finish and give a quick summary, I did want to say there's also a role for high-cost simulation as well. That we do a lot of it here. So this is the phase 3 of one of our trials where we're using mixed reality to capture open hand movements. We do 3D printing molding techniques. This is one of the models we're perfecting for a laparoscopic polymyopathy, which we can operate on the baby model, and we're validating that. Top-away model as well, and also using posture sensors and wearable technology to improve ergonomics within the operating theatre as well. But in summary, low-cost simulation can have a real-world high impact in low-resource settings and can have high fidelity. But true partnership and local clinicians and educators is essential. And evaluation and assessment is vital for this to happen, because you need to assess the clinical impact. And that's one of the great things that you need to achieve, is not just that it's word, not just that you get self-rated confidence increases, but actually that there is a downstream effect for actually patient management. So thank you very much for the invitation to speak, and thank you for sharing our experiences. And we're very welcome to anyone to join us in Melbourne. You can see even Darth Vader has joined our simulation centre and was giving a little seminar, which is the joy of working in a children's hospital and being from there.
Professor Nataraja, very inspiring talk, and I love the way, you know, you have really brought kind of a practical framework to the simulation and kind of linked this to, you know, an impact, you know, not only in Australia, but you know, really at a global health level. And you know, 2 years ago, we actually had John Miera here from Harvard, and we were kind of talking about, you know, the Lancet Commission and global health, and you know, the importance of enhancing access to surgery. So this really is kind of resonating full circle. So I think we've left some time for questions. So if there are questions from the audience, Professor Swallow.
Yes, great talk. Thank you very much. And for your visit in general and spending so much time with many of our learners and faculty. Just interested in your experience with the non-technical cognitive skill simulation and evaluation. And if you could comment on the extent to which language and culture may play into your ability to objectively train and evaluate people's ability to acquire those skills and retain those skills. I just think about de-escalation and how differently that plays out in different settings.
No, great questions. Thank you. So I guess that the first part is that you can really, cognitive skills are an essential part of what we do. And actually teaching them and assessing them is actually relatively easy in our setting. But it's something foreign for surgeons. So certainly our programs, when we built up a program initially just with cognitive skills, no one wanted to do it. So you then put in the laparoscopy, and then people actually enjoy the cognitive skills more. And so it's almost you need to tempt them in, and when people give you feedback at the end of the courses, those are the kind of things they really say are valuable actually, is learning the cognitive skills. And there's various framework we can use to then assess them and actually how they then actually improvements in communication skills. And there are objective measures you can, and scoring systems and frameworks you can do that for. We use video debriefing a lot in our setting. So of course you need to have a center with cameras and to record that, which we do. And I think your in answer to your question about the cultural, that's vital. And I think the only, it's not only the cultural implications of language, but it's also hierarchy is different. So hopefully nowadays we're going to more a plane level hierarchy within our operating theatres. That's not the case necessarily in low resource settings. So what we tend to do there's two mechanisms we do it. One, we model it. So when we're running a cognitive scenario through it, as faculty, we'll model it first. So we'll model it, and I'll make sure that I get involved in that as well, and then I'm getting feedback as well. So sort of trying to break down those barriers and trying to break down that hierarchy. But there's only so much you can go. And the other thing is then to have the partnership with our local partners and to run things through them first and have an honest relationship with them, which develops over time as well, where they can then give you feedback and say, and as in Myanmar and in the Pacific Islands, say, Ram, this just isn't going to work. We appreciate that, you know, this is a good idea, but it's not going to work. And then eventually, you know, throughout the years, then you can start to introduce it again. But the partnership and really, with my lens, I can never be 100% culturally sensitive. So you have to listen to your partners on the ground. Yeah.
Thank you. Dr. Hamstra.
Yeah. Thanks, Dr. Nataraja. Great to hear your talk. I had one question about mandatory training, and then another follow-up contextual about the larger obligation to society. So I think you said that a couple of jurisdictions have established mandatory training involving simulation. So my question there would be, who did you have to convince, and what criteria did they use to justify that decision? And the context is the larger question of, maintenance of competence. What would it take here in our jurisdiction maybe to have simulation be mandatory throughout one's career?
Great questions, thank you. So I think the mandatory training evolved, and I think for us it was relatively straightforward at Fiji National University because colleagues from the Royal Australasian College of Surgeons had helped them with their curriculum development prior to us going in country, so decades ago. And actually our curriculum for the MOST course and then the pivots is actually based on the general surgical curriculum. So there were a lot of resonances there. So because we'd formed the course based on the Australasian curriculum and they'd actually then adapted the Australasian curriculum, there was a lot of resonance between the two. So for that aspect, we could then say that these are our learning objectives, this is what we achieve. And for them, they could say, well, actually, that's what we're trying to teach as well. And we're happy with this. But then you demonstrate it. So we did a pilot study, people went through it, they then assessed it, we had faculty through it from FNU, and then they said, yes, this is great, we need to now make it mandatory training. The mandatory training is not sometimes without its issues, and I think that mandating something means that you sometimes have some learners who just don't engage. But that's an art of education to engage those ones, and if you can't engage them, which happens rarely, but if you can't, then minimising the impact on other learners of their involvement. But and the second one about maintaining skills, I think it's interesting, isn't it? And I think it's a big debate, and I think certainly for myself, it seems to be this magical thing when you get your letters where you are then uber competent, and you are. You've been assessed for competency, you are there. But as we know, that skills do degrade, and there's always a learning curve if you haven't done something for a while. I think it'd be hard to mandate that as maintenance, but I think that it's one of those things that will be introduced it and people started to do it and seeing the benefit of it, then there would be that snowball effect of then changing practice. And so, as I said, pilots are mandated to do hundreds of hours per year, and it's just what they do. It's just like that's what they have. And I wonder whether there's systems that we can do similar to that, where we create a community of practice amongst our expert surgeons who then come in and share experiences of clinical exposure, of cases, of experience. I think the word I've heard a lot in the last few days is boot camp, but you'd have to do that as a expert level, not as a mixture between different levels. So I think you'd have to target it, as some of the interventions already did, at a certain level, and then keep it nice and controlled within that. Because I think part of that is actually creating a safe environment to make mistakes. And you also, there's a lot of credibility to what we do, and if you make a mistake in front of your trainee, yes, you can verbalize it, and a lot of people are talking about that notion of verbalizing it and talking through this, which is incredibly powerful to learn from. But it also will have an effect on professional identity, ongoing relationships, and things like that. So I think you'd need to construct it very carefully, just looking at all of those different aspects.
Very good. Professor Rutka.
Yeah, thanks very much, Graham. That was very inspiring. And my question is more about, it's low cost, you mentioned, but it's not no cost. There's a cost for sending, I'm sure, these simulators to all these countries, cost for the video capture devices, cost for your time and all your colleagues' time and so on. And what's your government situation like for applying for funds to support these types of research and also clinical care questions, or is it local? Is it private philanthropy? What do you do to fund the costs? Even though they're small, they're real, I'm sure.
No, they are, and it's a great question, and it's a mixture, to be honest. So FRACS gets funding from DFAT, which is our Department of Foreign Aid and Trade, which is a government level. Modest grants, small in terms of what they're used to dealing with, but the cost of the infrastructure is not huge. I mean, the simulators are less than $1,000 each, so you've got 50 of them through there. That's not a huge amount in terms of a governmental budget to actually go through. But it's also proving, and one of the powerful things we found is that you need to evaluate your program. So there's two aspects to that. The first aspect to me as an educator is actually worth it. Am I actually making an impact? Are my learners actually changing their practice? Is that worth me spending my time and effort? Because as you pointed out, a lot of us do this voluntarily, and we donate my time to it. And then you have the aspect of the evaluation is then to prove impact to benefactors, to philanthropy. And actually, if you can demonstrate that you have an impact, like we did in Myanmar, that then attracts funding for projects, because benefactors and philanthropists will like to see that their money has actually gone to something rather than we went in country, it seemed to be great. Here's a few photos of us all enjoying laparoscopy, but then actually to have the effects of that and prove it. And it's only one step, because the next step is actually, now that they're introducing laparoscopy in the Pacific, is actually to then, and that's why we're training with the research course, that the master's students who go through our program now collect data and actually show the impact that it has in the clinical setting, and we get that buy-in as well, which then attracts funding.
And you're fairly young still, but sustainability and succession planning, have you thought through that? Because you've been running this program, I'm sure, for a decade or more, but who's to follow you in this? Yeah,
it's a great question, and I think Demir. So Demir was my simulation fellow 10 years ago, and he's just got his letters this year. So he's brought him on with us. So he's an amazing educator. He'll do far better than I will do in my career, and he's going to take over as well. But one of the key things to us is actually to become supernumerary. Like we did in Myanmar. So that's why we're training Haiku, Abe and Julia in educational theory, in getting educational qualifications so that they can actually then have post-nominals, and also then, one, the ability, but then two, also the credibility to then continue the programs. And it doesn't mean that we do ourselves out of a job. They still need our help, and there will still be other things that we need to help them with, and we can then do, and we can bring in different expertise. But it'll mean maybe in 10 years' time, Pivots is run completely by them, and we're then helping them with another clinical governance. And part of the WHO work we did in Fiji was sterilization, and really helping them with the sterilization and different things like that. So there's so much you can do there. We're not doing ourselves out of a job in that country, but we're handing over components that once they're being tried and tested, and we train them up to then deliver locally.
Very good. And perhaps the final question from over here.
Thank you. That was a terrific talk. Joanna Rozelle from Sick Kids. I think there's often a big gap between feeling comfortable in a simulated environment and then feeling comfortable on your own, in the real world or in the operating room, as many practitioners are in a limited resource setting. And so your work in Myanmar really reminded me of that. And I wondered if there's any opportunity for continued partnership and mentorship when people sort of graduate from taking those skills in the simulated environment then into the real world. And would that potentially impact that conversion rate at all?
It would, yeah, and I think that's vital. And I agree with everything that you've said. We're starting a scholarship program next year, which is going to be a 2-week program in whatever they want. So they're going to apply for it. So it could be ED, it could be nursing, neonatology, surgery. And we're doing 2-week targeted program, but then a year of mentorship following that. So actually where they then form a relationship with one of our experienced team at Monash, who then mentors them through it. They have regular meetings, they go through. And it's a very powerful thing for that to happen because it's outside of their setting. And part of the reason the most course works so well is that we're pediatric surgeons, but we're teaching general surgeons and O&G trainees or preset trainees who want to become trainees. And so they don't feel threatened because they know that, they can make mistakes, they can get corrected, they can have frank discussions with me, and they'll never then walk into an interview panel and see me sitting opposite them, which, even if that happened, I would hopefully have the integrity where it wouldn't affect, but they would worry about that. So the mentorship, I think, is a key thing, and that's a very valuable point. Yeah.
Great. So I think on that note, we'll close out our 2026 Gordon Murray Lectureship. Professor Nataraja, thank you so much for a fantastic talk. Very inspiring. And I'm sure Ram is open to some informal discussion. So we're going to now segue to our second e-poster session, which will be upstairs. There's coffee and refreshments outside. We'll reconvene in exactly an hour at 3 o'clock for the second part of our oral presentations from our trainees.